Dr. Heng is a medical oncologist, and he did his medicine degree here at in Calgary at U of C, and then he did internal medicine and medical oncology residences at the University of British Columbia. He did experimental therapeutics fellowship at Cleveland Clinic, Tausig Cancer Institute, and he's currently the chair of Genitourology Tumor Group in Calgary, as well as the chair of the International Metastatic Renal Cell Carcinoma Consortium database here in Calgary. This includes 25 centers worldwide, and we're looking forward to hearing him and how he can how we can deal with advanced prostate cancer and what can be done to help us.
Well, thank you very much for coming. So I'm Danny Heng. I'm one of the medical oncologists at the Tom Baker Cancer Center. Oh, can you hear me? Yeah. All right. A little closer? Okay. There we go. Is that better for everyone at the back? Okay, excellent. So I'm Danny Heng. I'm one of the medical oncologists at the Tom Baker Cancer Center here in Calgary, and I've been tasked with talking about metastatic prostate cancer. What can we do for you? And before I proceed, I want to thank you for coming, because it means that you're interested in prostate cancer. It means you're interested in building awareness about prostate cancer, or that you have a loved one with prostate cancer that you really care for. And so I think it's really important that we get information and become aware of prostate cancer and what we can do and how we can help. So you've seen this graphic from you guys, yourself actually, from Prostate Cancer Canada. Prostate cancer is a really important disease because actually 1 in 8 men in Canada will get prostate cancer. And 1 in 4 men with cancer in general, it'll be prostate cancer. In the year 2015 alone, 24,000 men will be diagnosed with prostate cancer, and unfortunately 4,100 will pass away due to advanced disease. The good news, though, is that things are changing, and I have so many slides later on to show you how things are changing. There really is a treatment revolution over the past 3 to 5 years. There are these new drugs and all this research coming out that's really, really exciting. And so it's actually led to an improvement in how long people survive with prostate cancer. So from 2001 to 2009, there's been a 4% decrease in the death rate. And it's because of good screening, so with PSA screening, but also better treatment options, and I'll talk about that in just a bit. So, you know about localized prostate cancer and early prostate cancer. Those are synonyms. They mean the same thing. And so that's not what I'm going to be talking about. So localized prostate cancer is it's just in the prostate. We're going to take it out with a prostatectomy or with surgery, or we're going to watch it with active surveillance, or we're going to do radiation. That's localized prostate cancer or early prostate cancer, and I'm not going to talk about that today, okay, because that's not going to be the focus of my talk. What I will be talking about is metastatic prostate cancer. So what happens if prostate cancer has moved to the bones, lungs, lymph nodes, brain, or what have you? What can we do about that? And here's an example here. It's difficult to see probably from the back because of the lighting, but you can see the prostate right there glowing in the dark basically on a PET scan because it's really active, and it's moved on to the rib. There's a site here in the rib that's hot, and that's what a PET scan, when we change colors and color code it, that's what it looks like to us. So I'll be talking about metastatic prostate cancer. So some of you in the room might be people whose PSA has come back, actually. It's actually gone up a little bit, even though they've taken their prostate out already. You're also not included in this metastatic prostate cancer group, okay? This is only people where the cancer has spread to the bone or outside the prostate. So where does prostate cancer spread to? There are 2 most common sites that prostate cancer spreads to are bone and the lymph nodes. So here's a bone scan, and so I know it looks black and white and gray. It really is this boring on a bone scan picture, but basically it looks at all of the bones in the skeleton, and anything really black means that there's a lot of activity there. And so you could see in these pictures here that there's blackness thickness in the pelvis there, in this pelvic area, and that means that the prostate cancer has spread to that area. The second, another common place is lymph node metastases. What are lymph nodes? Lymph nodes are these little green things here. It's normal to have lymph nodes. They're scattered all across the body. You have lymph nodes in your neck, you have lymph nodes in your armpits, in your chest, you have lymph nodes everywhere actually, but a normal lymph node is less than 1 centimeter. So if something's more than 1 centimeter, so if we do a CT scan and we see there's something that's 2 centimeters or 3 centimeters, that suggests that there's something wrong, there's something going on there, and maybe the prostate cancer has moved on somewhere else. So that's where the lymph nodes are. You can't feel lymph nodes that are usually deep down in there from prostate cancer. Usually it's detected by a CT scan. So if prostate cancer has moved on, if it's metastatic prostate cancer, what are our goals? What are we trying to achieve? So what we can do is we can give patients treatment. And what does the treatment accomplish? The treatment can accomplish making people live longer. So we know that by giving people treatments, compared to not giving them treatments, they definitely live longer. And in fact, today's treatments are much better than treatments from 3 years ago, 5 years ago, and we've actually extended people how long they've lived by many, many, many months, almost doubled certain numbers actually. What's important is we make people live longer, but with a better quality of life. Because you might be thinking, well, you could make me live longer, but if it's with a poor quality of life, who cares? But actually, we can make you better with a better quality of life. And you can still go to play golf, for example. The second thing we do is we make symptoms better. So if you have some pain, for example, some bone pain here that won't go away because there's a prostate cancer bone metastasis here, we can actually make that pain get better. If you were taking morphine or if you're taking drugs to make that better, we can actually settle that down a bit so that you take less morphine or no morphine at all. We can shrink down tumors and prevent them from growing. So if we repeat the CT scan, we can actually see that some of the lymph nodes are shrinking. If we do a bone scan, we can actually see that some of the things on the bone scan are not as black. They're a little bit grayer or whiter, and so that's better. And finally, we can prevent further spread of the tumor. So instead of developing 5 new bone metastases, the next time we do a CT scan or bone scan, we don't see that because you're on treatment. With someone with metastatic prostate cancer that's already spread to other organs, we can't cure you. So no one can offer you a cure. If they're offering you a cure, they must be from the 23rd century or 22nd century or something like that. But what we can do, though, is control it really, really well. All right? We can control it for many years with pills, with hormone shots, so that you can have a good quality of life. And so we'll talk about that in just a bit. What I'd like to talk about, though, is just what the natural progression of metastatic prostate cancer is. So what is the typical course of metastatic prostate cancer? What happens? There's always 2 stages to metastatic prostate cancer. The first stage is castrate sensitive. So what that means is, prostate cancer really needs testosterone. Testosterone drives prostate cancer. I always tell my patients, and many of my patients are in this room actually, so it's kind of good to see you. Hello. What prostate cancer needs is testosterone. And so testosterone is sort of like the food, and the prostate cancer with its androgen receptor, that's like the mouth. And the mouth wants to eat the food to feed itself. And so what we do is if we take away that testosterone, well, all of a sudden that mouth has nothing to eat anymore. The prostate cancer cell is starving. It can't do anything. It can't grow. It dies. And so almost all prostate cancers are very susceptible to hormonal manipulation. If we take away the testosterone, the prostate cancer dies and your PSA falls. And so that's called castrate-sensitive disease, where we've essentially castrated you by giving you an injection to stop testosterone production, and that works for 99% of the time. The PSA falls, you feel better, and it actually lasts for a very long time. Unfortunately, invariably, 100% of the time, hormone therapy eventually stops working. So eventually, even though you're on these hormone shots, the PSA will go up or bone pain will start to come back and stuff like that. And that's when we get into the castrate-resistant zone. So that's the second step. That's the next stage of metastatic prostate cancer, where the prostate cancer knows you're getting an injection every 6 months or every 3 months, and it knows that you've driven the testosterone all the way down, but it doesn't care. It's found other ways of living and surviving. And so that's called castrate-resistant prostate cancer. But believe it or not, we have tons of drugs to deal with castrate-resistant prostate cancer. And so that's one of the things we're going to talk about. So for castrate-sensitive disease, we give these hormone shots. I don't know how many people in the room are on hormone shots, but basically it's a shot that you give. There are various preparations. Some you give every 3 months, 4 months, some you give every 6 months. I usually give a 6-month shot, and it goes into the stomach here. Usually one of our nurses gives it to you. We don't make you give it to yourself. And what it does is it's a depot that goes into the skin, and it slowly releases an anti-hormone. And what that does is it prevents your own body, it prevents your testicles from making testosterone. So that's the key, isn't it? If you have prostate cancer and it's driven by testosterone because it eats testosterone, if you prevent your own body by making testosterone, prevent it from making testosterone, that prostate cancer is going to die off and it's not going to be able to thrive. And invariably that works very, very well. But eventually, we get progression of the prostate cancer. And so this is sort of a diagram here that details castrate-resistant prostate cancer. So that's an entity where the hormone shots don't work anymore. Castrate-resistant prostate cancer. So oftentimes someone's PSA rises and you don't really have metastases, but eventually you do develop metastases. And at first you don't really have symptoms from those metastases, but eventually they do become symptomatic. And at each of those points, that's a certain disease entity that we can treat, that we can give treatments to extend your life and to make you feel better. So that's what our job is, to treat prostate cancer that's metastatic, even if it is castrate-resistant. So people at the Rocky View Hospital, the Southern Alberta Institute for Urology, or the Prostate Cancer Center, what they do is they treat localized prostate cancer. They also treat metastatic prostate cancer that can be treated with hormones. But once the hormones stop working, usually our good friends at the Prostate Cancer Center refer you to us at the Tom Baker Cancer Center to talk about other treatments for castrate-resistant prostate cancer. So for the scientists and engineers in the room, and I know there are scientists and engineers in the room, there might even be nurses and doctors in the room too, but everyone is always interested in, why did my cancer not respond to the hormone therapy? And so there's a very complicated diagram here, but basically there are many theories as to why the prostate cancer no longer remains responsive to hormonal therapy. First, when we give the hormone therapy, we kill off cancer cells, but we might be killing off only the really susceptible cancer cells and leaving behind the really aggressive cancer cells. And so those really aggressive cancer cells can sort of hide somewhere, stay there, be dormant for a while, and then suddenly reactivate. And maybe it doesn't need as much testosterone as other prostate cancer cells because we've actually selected those people, selected those prostate cancer cells that do survive. On this long axis over here, there are many different other possibilities, and I won't bore you with them, but basically, the prostate cancer cell can make its own testosterone or something like it to feed itself, or it could actually learn to use some of the drugs that we give, like Castratex, to use it as food to drive that prostate cancer. Maybe it doesn't need your own testosterone, or maybe it just makes itself think that it's eating all the time and it's okay. There's actually something where it doesn't need testosterone anymore. It just grows because it's perfectly fine without testosterone. It's a mutation that the cancer cell can have. So those are some of the mechanisms that prostate cancer cells can develop a resistance towards our hormonal therapy. So there's always a disease continuum of how prostate cancer goes. And so usually at the very beginning, we treat people with local therapy for non-metastatic disease. So local therapy, it's just in the prostate, so we either use radiation or prostatectomy, or we take it out. But it may recur over some time. And if it recurs, your PSA goes up. And so some of you in the room, your PSA might be going up. And we might have to put you on hormone therapy, those injections that we talk about. And then the injections always work, so your PSA goes down like that. But then eventually you'll need second-line therapies. And eventually you'll need third-line therapies, other drugs like Abiraterone, Radium, zoledronic acid. There are all these names here. And I'll go into those because I know it can be very confusing. Basically, how we use these drugs is in sequence. So we don't use the drugs together. We don't combine the drugs together. We haven't shown any benefit to combining drugs yet. We may one day. But basically, we use one drug until it stops working. And if that stops working, we move on to another drug. And that starts working. And then eventually it stops working, so we move on to another drug. So we use it in sequence, one after another, depending on whether or not it's working. Okay? So how we treat metastatic prostate cancer is with a combination of hormone shots, pills, chemotherapy, radioisotopes, radiation, bone protector therapies. We don't use them all at once. We use them in sequence to each other. But that's our armamentarium. We've got all of these things to help fight your prostate cancer, to help fend it, try to prevent it from getting worse. And so let's go into a little bit more detail. I love this cartoon. I found it off the internet, totally pillaged, so I apologize. So we talked about castrate-sensitive disease, and we talked about castrate-resistant disease. So for castrate-sensitive disease, we have those hormone injections, because the hormone injections will work 99% of the time. Sometimes we use hormone pills like Castratex, and we might use it, for maybe 1 month when you start the hormone injections, or we might use it throughout the time that you're on hormone injections. It depends on the circumstance. Something that's new, though, and actually, by the way, everything highlighted in yellow is something that's new that's been developed over the past 5 years. So that's pretty exciting. It shows the pace of development of prostate cancer. Something that's new in the castrate-sensitive world is we didn't used to give chemotherapy, but now we do. We give 6 cycles of docetaxel chemotherapy, and it actually pushes castrate-resistant disease really, really far off into the future. And people actually live something like 17 months longer than people that didn't have that chemotherapy up front. So that's something that's fairly new that we've only done for about a year worldwide. These results were just presented last year. So now we've been doing it for the last year, giving chemotherapy up front for people with metastatic disease that's still responsive to hormone therapy. They're called hormone-sensitive patients. We give them 6 cycles of docetaxel chemotherapy. So after doing all that for the castrate-sensitive disease, and that can take several years, all right? So some people might not develop castrate-resistant disease for 3 years, 4 years, 5 years, maybe more. You might be on the hormone shots for a very, very long time, measured in years. Eventually, you develop castrate-resistant disease. And castrate-resistant disease can be treated with a variety of these things. So I said everything in yellow is something new in the last 3 to 5 years. So you can see 3 to 5 years ago, we only had docetaxel chemotherapy. That's all we had, docetaxel chemotherapy. But now we have all these other drugs, and I'm going to go over them one by one. Hopefully, when I go over them, I'll go over them in an understandable fashion. If you have questions, please feel free to raise your hand, because I'd love to make this interactive and make it very, very understandable. So, enzalutamide. Enzalutamide is a drug that we use for castrate-resistant metastatic prostate cancer. So the hormone shots stopped working. We're still using the hormone shots anyway, even if it stopped working. We still continue them, because if we stop them, your testosterone can flare. So even with using these hormone shots, we add in another drug called enzalutamide, for example. In blue, for all of the next few slides, in blue I put the trade name because, you know, us doctors were really confusing people, and we like to use 2 names for every drug. Who knows why? I don't know why. We want to sound professional or whatever, but those are the 2 names of exactly the same thing, all right? So you might see in the paper Xtandi, but it's actually enzalutamide. They're exactly the same thing, okay? One's just the normal name, and one's the generic name, one's the trade name. All right. So what enzalutamide does is it's a pill, and what it is, it's sort of the blocker. So it blocks the androgen receptor. So testosterone cannot go to this androgen receptor. The androgen receptor is what eats the testosterone, if you remember. So if there's something blocking that mouth so that testosterone can't bind or can't go into this mouth for the prostate cancer cell to eat it, then the prostate cancer cell can't thrive. And if it can't thrive, your PSA will go down, you'll feel better, bone metastases will get better and feel better. That's what enzalutamide does, okay? We've been involved in clinical trials of enzalutamide, and it's been very, very, very worthwhile. We've had people with Lazarus effects, where people are literally so much in pain, they're in wheelchairs, and then you give them enzalutamide, and you know, a few weeks later, they're starting to walk again, and then a few weeks later, they're gardening, and then a few weeks later, they're going to Las Vegas. And so that does happen, okay? And so it doesn't happen for everyone, but it is possible, and it's one of the drugs that have really revolutionized how we treat prostate cancer, because it's just a pill.
Sorry.
Yeah.
I have a question.
Of course.
You said you don't combine pills.
Mm-hmm.
We heard in the Warriors group one gentleman today, he's on Eligard and Xtandi together. He's been treated it together.
Correct, yeah. So we actually use the hormone therapy all the time. So the Eligard is sort of the exception to that rule, because Eligard you need to be on all the time no matter what when you have metastatic disease. So you'll always be getting those shots, and then you take this on top of that, all right? But what I mean is that we don't usually combine enzalutamide with abiraterone, for example, or at least not yet. Our clinical trials haven't told us to do that yet. And we do have clinical trials on those combinations, but they're still experimental, and we need to see whether or not they actually prove to be of benefit in the future.
Some people might have Xtandi and not be on Eligard?
Usually not. Usually people are on Eligard all the way through, and they're on the Xtandi. Yeah, absolutely. So sorry for that confusion. The next pill that I want to talk about is abiraterone. So abiraterone is given with another pill called prednisone, okay? And so it's given, it's 2 pills actually, 2 different types of pills, and the trade name is Zytiga. And so what that does is, you know, I just told you that these hormone shots prevent your testicles from making testosterone, but abiraterone actually really shuts down your testosterone production in your body, because not only does your testicles produce testosterone, but other parts of the body does as well, such as the adrenal glands, even the prostate itself, and there are enzymes in the body that actually convert things into testosterone, and so that's what abiraterone prevents it from doing. And so abiraterone actually blocks an enzyme that creates something like testosterone. So again, you're lowering the amount of food in the body. So you've got this big fat cancer cell here, but it turns into a starving, sickly cancer cell there because it has nothing to eat, because there's even less food out there. There's even less testosterone out there for it to eat, okay? So abiraterone is also a pill. It's also one of the pills that we've seen Lazarus effects on, and it's been very, very good. The next treatment is docetaxel. So docetaxel is a chemotherapy. Its trade name is called Taxotere, and its job is to kill cancer cells. That's essentially what it does. It kills cancer cells. So it's called cytotoxic chemotherapy, and that's a fancy way of saying it kills cancer cells, all right? What it does is it prevents for the scientists in the room, it prevents the cells from dividing properly. And so normally cells need things to pull the cells apart, but for some reason, but the docetaxel actually prevents that from happening. These things that pull the cells apart actually just stay like that, and it gets stuck, and then the cancer cell knows it's stuck, so it dies. And so basically that's what docetaxel does. It is chemotherapy. It's given IV. It's given every 3 3 weeks. The side effects, can include a little bit of nausea, not much nausea actually. Sometimes people can have lowered immune systems. They can have numbness and tingling in their fingertips and toes. They could get diarrhea, but actually it's a very tolerable chemotherapy. There are people in their 80s that get this chemotherapy because it's specifically suited for people with prostate cancer. So that's Taxotere or docetaxel, and that's a chemotherapy used for castrate-resistant prostate cancer. One of the newer chemotherapy is something called cabazitaxel or Gevtana. That's the trade name. And what it does also, it's chemotherapy, it's also cytotoxic chemotherapy, so it also kills cancer cells. But specifically, this kills cancer cells even after docetaxel stops working. So for example, if you've been on docetaxel for a long time, been on it for 12 cycles, for example, and then it stopped working, you can use cabazitaxel and it has a good chance of working after that too, okay? So just because one chemotherapy stops working doesn't mean another chemotherapy won't work. And so that's what cabazitaxel is. It's another chemotherapy that also kills cancer cells. And here's another one. So this is sipuleucel T. So sipuleucel T is very difficult to spell. You always have to spell check it on Google, but it's very difficult to spell. Its trade name is Provenge. It's actually not offered in Canada. It's really expensive. It's $90,000 if you want it, and so $90,000 is a lot for the healthcare system to stomach. But the main reason why it's not reimbursed and funded, because we have $90,000 drugs that are funded, is because the benefit is actually quite small. So it's not like docetaxel chemotherapy that I was talking about before, where it extends your life by 17 months. It doesn't do that. It may extend life by maybe 3 months. And there are also questions about how the clinical trial was designed, because it doesn't have any benefit on your PSA or progression, time to progression. So a lot of people are sort of scratching their heads and wondering, well, does it actually work then if it doesn't affect progression? So I think this drug is a little bit controversial, but nevertheless it is FDA approved. You can get it in the States. It's supposed to be used fairly early on in the castrate-resistant realm, but quite honestly, there's a lot of controversy as to its benefit. So Provenge, it's a vaccine. What it does is a little bit complicated. We take out your blood and we actually isolate immune cells in your blood, and they put them together with prostate cancer antigens to create your very own vaccine using your own immune system. And then the idea is to inject it back into you. So they inject that liquid back into you with all the cells, and the idea is that those cells will divide and stimulate an immune response so that your immune system actually attacks the prostate cancer. So that's the idea behind sipuleucel T. One day, hopefully, we'll have a sipuleucel T that's a little bit more targeted, that might be maybe using your own prostate cancer tumor cells or something like that, and then maybe it'll provide more of a benefit. But right now, its use is a bit controversial, and we don't know quite where to place it quite yet. And then here's Radium-223. So Radium-223 is kind of exciting, actually. It's very interesting, and it'll probably be reimbursed soon. And what it is, it's a radioisotope. So it's an injection, a radioactive injection. So when you go to the airport, you'll actually be stopped at the airport because you've got nuclearness in you. And so, that's something, but it goes away really quickly. But basically what it is it's radium that is radioactive, and radium in the periodic table, so for the chemists in the room, under calcium in the periodic table there's radium, and calcium and radium, they all go to the bones. So what it does is this drug goes straight to the bones, and then it releases radiation. And luckily, it doesn't release radiation like this and sort of blow everything up. That's what we think of radiation. But it actually just releases it no more than 10 cell widths away. So that's even smaller than this. I can't even make 10 cell widths away. It's really, really tiny. So what that means is it delivers radiation to a lot of places very close to the bone, but it doesn't deliver radiation anywhere else that could hurt things, all right? So actually the side effect profile for radium-223 isn't that bad because it really just stays in the bones. What it has been shown to do is improve overall survival, so people live longer after getting radium-223. We still have questions about whether or not it actually improves bone pain, and it's really important to know that this drug is not good for people with liver metastases, people with lung metastases, people with lots of lymph nodes. This drug doesn't work on any of those things. This drug only works on the bone. So really the ideal candidate for this drug is really someone with just bone metastases and not much else, because it doesn't go to anywhere else other than the bone. Okay. So this drug, like I said, is going through the approval processes here in Alberta, and so we should have it available for you. We're still deciding where to fit it exactly, because there's so many other good drugs that we can use too, and this drug was studied in the time before we really had those good drugs to use. So that's radium-223, Xofigo. You'll hear more about this in the future. And then there are bone-building drugs. So bone health in prostate cancer is actually really important. And the reason is because a lot of the drugs that we give you actually thin your bones. So those hormone injections that you've been getting for 5 years, maybe 10 years, it slowly thins your bones. So bone health is really important. So taking calcium, taking vitamin D is important. But when you get to the castrate-resistant zone, bone health is even more important, because then you're more at risk of getting a fracture or getting a pain crisis that really requires radiation because it hurts so much. Or maybe the bone releases a lot of calcium and you have too much calcium in your body. And so those are things called skeletal-related events. And what these drugs do is they prevent those skeletal-related events from happening. So preventing you from needing radiation, preventing you from your calcium levels from going too high, preventing you from fracturing your bone accidentally by not doing anything because your bone structure is weak. That's what these drugs do. These drugs don't take away that risk completely. They don't make you Superman so you can go jump off, high towers with leaps and bounds or anything like that. You should still be safe and stay away from contact sports, but it does decrease your risk of fracture. And so that's why these drugs can be helpful. So denosumab, zoledronic acid, these are available, and you can talk to your doctor about bone health.
Just a question on these
Yeah.
two. Are they currently funded in Alberta?
That's a great question. So denosumab is not funded unless you have an insurance program. So if you have your own insurance program, a third-party insurance, it will fund it. Zoledronic acid in Calgary is available by IV. And so usually for patients that don't have coverage, we give zoledronic acid. In all of Alberta, though, it's a bit of an issue because zoledronic acid is not funded. And so we have to find other ways of funding the zoledronic acid. And so that's why I think it's really important to have drug coverage, but also to ask your physicians about this, because the more we push, the more likely one day these will be funded for everyone.
Is the cost a factor in that decision?
It's not too much of a factor. I'd say, and don't quote me on these prices, I'm not for certain, but it's about $400 a month. So it's definitely cheaper than the $90,000 treatment. It's definitely cheaper than Abiraterone, which is $4,000 to $5,000 a month. And so these are very, very expensive drugs that we have. And you can imagine it's hard for the government to fund everything because it's very expensive. And so we have to be very judicious about what's available.
So, excuse me, out of all the drugs that you talked about, which ones are not funded?
So all of them are. So all of them are except for the radium-223, but that's coming up really soon. Sipuleucel T is not funded and probably will never be funded in Canada. And denosumab and zoledronic acid, the reason why it's not officially funded now is because it doesn't improve survival for prostate cancer. So it doesn't actually kill prostate cancer cells. It just strengthens your bones. And so it's sort of like an adjunctive therapy, sort of like calcium and vitamin D that you take. So we don't pay for your calcium and vitamin D because it doesn't actually kill the prostate cancer cells itself. But everything else, the docetaxel, cabazitaxel, abiraterone, enzalutamide, and those are really, really expensive drugs, those are funded. So what's a typical example? Because I just threw a whole ton of names at you and it's really confusing. So a typical example is this. This is a man's journey with metastatic prostate cancer. I'm not saying this is everyone. I'm saying this is, sort of typical. Everyone's different. Some people it happens a lot faster. Some people it happens a lot slower, so that's good. But basically, people usually start off with castrate-sensitive disease, where everyone's prostate cancer is responsive to hormonal therapy. And so you're often on that hormonal therapy for quite some time. And then years later, and I underline years because it really can take years later, you develop castrate-resistant disease where those hormone shots are wearing off. You still need to continue them because we know that if you stop them, then it can reactivate the testosterone, and that's not good because testosterone is food for the prostate cancer. But it's not good enough on its own. So we have to add something else. So what else do we add? Well, this is a very typical sequence. And this is just one sequence. There are many other sequences that can happen, but I just wanted to give you an example so that you have something concrete in your mind. So what we can do is we continue these hormone shots, and then we put someone on abiraterone. And that lasts for a very long time, let's say a year and a half, 2 years. And then it stops working eventually, so we move them to docetaxel chemotherapy. That works for a long time, and then eventually it stops working, and then we move on to enzalutamide, then cabazitaxel. And maybe a bone hurts, the rib that really, really hurts, and you just want it to go away, so we can actually just give radiation and make it go away and make it feel better, and then it doesn't bother you anymore. So that's a very typical sequence that can happen. Stuart, did you have a question?
Yes. Just today, I've had 3 conversations with different people, and they actually come from Fort Chip all the way down to almost the border. And how does the factor of age of the patient come into your consideration of this sequencing of the various drugs?
That's a very good question. So we don't usually use chronological age, so the actual number isn't important to us, but what you look like and how truly old your body is, all right? So someone could be 86 years old, but they look 60. We have lots of those patients. Those patients, for sure, we send for chemotherapy if we need to. But there are some people that are 60 that look like 86-year-olds, which might be, which may be a little bit tougher. And so we might not want to use chemotherapy as much just because we might not be able to tolerate it. That being said, we've treated lots of people with chemotherapy that are in their 80s. And so really, age isn't a limiting factor. It's more everything else that's going on. Do you have diabetes? Are you very frail? Can you walk? Can you climb stairs? Can you look after yourself? Those are the things that I ask to see if you're eligible for chemotherapy. Really, the age doesn't really matter as much.
And just as a follow-up to that, of course, I'm not in a position of giving advice, but we do feel that in some situations when there's perhaps the patient wondering why the recommendation has been such as you may be given, and it could well be age-related, how do they seek a second opinion?
That's a good question. So the best way to seek a second opinion is actually just to ask the physician. And the physician, we actually have in Alberta something called the Multidisciplinary Tumor Board. And in fact, it's not just Alberta, everywhere has it. But basically a bunch of oncologists, radiation oncologists, medical oncologists, urologists, we all get together, sit around a table, and we bring up cases such as second opinions or cases that are difficult that we don't really know what to do with, or something with controversy, and we talk about it to come up with the best plan. So in that sense, you sort of get a free second, third, third, fourth, fifth opinion, and then we go from there. If you're still unhappy with that, you can still ask your physician or ask your family doctor to send another referral in. But we usually try to use the multidisciplinary tumor board as much as possible, just because it's an opportunity to get free consultation with a whole bunch of other people knowledgeable in that disease.
Thank you.
I heard that if you have to have chemo before you go on to Xtandi. Is that correct? Or if someone doesn't like the idea of having chemo, could they go to Xtandi and not have the chemo?
So it sort of changes with time, actually. So actually, right now, you can have Xtandi before chemotherapy as long as you haven't had Abiraterone, okay? And so the way we're funding drugs is really quickly evolving. So, so as of, I would say, a month ago, actually, that started happening, and we can give Xtandi before chemotherapy. In fact, there's a special access program on right now where you can get Xtandi anyway, and so actually there shouldn't be any reason why someone is having difficulty getting Xtandi, because there's an access program that's available. And so we can talk more about that later if you want.
You said as long as you haven't had
Abiraterone. So that's for provincial funding, but right now you don't have to have, those rules don't apply because there's a special access program that you can get those drugs on.
Who would make the decision to skip Abiraterone and go straight to Xtandi?
Oh, that's a good question. So for someone who's already had Abiraterone, should you go on Xtandi or not? And the problem is there are no good clinical trials to show us that that's even helpful. So there are lots of retrospective studies that show that there is some evidence to say that there might be some activity, but it's definitely not as good as using, those drugs up front. All right. So using them in sequence, Abiraterone, then enzalutamide, or enzalutamide, then Abiraterone. The second drug always is a little bit more disappointing than usual. And so that's why for people that are healthy and for that people whose prostate cancer is getting worse on one of those oral drugs, we actually prefer to use chemotherapy first, especially if they're symptomatic, just because it's a totally different mechanism of action. It doesn't deal with the hormone axis. It actually kills prostate cancer cells. And so that may be where the oncologist is coming from. I don't know who that patient is or their particulars. Maybe there's something, maybe there's a drug interaction where they can't have enzalutamide, or maybe there's some other reason why they can't have enzalutamide. So it's quite individual specific.
My question really was related to the choice between those two drugs and what you start on.
That's a
that
great
decision
question.
Is rather important.
It is, but basically it's one or the other. So right now, there's no evidence to say that one is better than the other. Enzalutamide or Abiraterone plus prednisone. There's no head-to-head clinical trial that says this one's much better than that one. So actually, you can use them interchangeably. We don't use them together, but you can use them interchangeably for now until we have more evidence. But the question is, should you use the other one right after? That's a bit controversial. For example, in BC, you can't do that. In British Columbia, you can't do that. In some other parts of Canada, you can't do that. You can't sequence it. But now that there's this special access program, you can, but knowing that the response rates might not be as good as with chemotherapy. Does that answer your question?
Slightly.
What is your question then?
Well, no, the choice to start with.
Yeah.
Whether you start with one or the other.
Yeah.
I don't know how you would make that decision.
It sort of is a toss-up. Because there's, like I said, there's no evidence to say one is better than the other. So really, it is a flip of a coin. There are a few things where it does matter. For example, Abiraterone, prednisone, if you had really bad heart failure and you couldn't take water retention because Abiraterone could potentially cause water retention, then you might want to shy away from that. Or in the rare circumstance in enzalutamide where you're on a drug and it interacts with enzalutamide, you don't want that either, so you might shy away from enzalutamide. But short of those fairly rare circumstances, there really is very little to guide us which one we should use, all right? So maybe that's why I'm not answering your question, because we don't know what the answer is. We don't know which drug is the best one to start off with.
Really, it's up to understanding the side effects and the individual patient.
Correct.
And discussing it to make a decision.
Correct, yeah. And unfortunately, there's no evidence to say one's better than the other. So really, unless there's a side effect problem or something like that, you're not wrong for starting one or the other. Did I answer your question now? Okay, good. I always aim to please. Excellent. Any other questions?
Just an observation from our Warriors group is that fatigue is a greater issue with Xtandi than it is with Zytiga.
Yeah, so fatigue is a side effect of Xtandi, and so for people who are already very fatigued, maybe it's also a drug to shy away from. It's hard to tease out if it's drug-related or if it's prostate cancer-related, where that fatigue comes from, but sometimes you and your oncologist can figure that out and decide. But you're right, short of those very rare circumstances, it's hard to decide which drug to start on next. So now I want to shift gears and move away from talking about drugs and talking about the rest of you, because the rest of you is just as important as the prostate cancer. And so I think it's important to recognize that we need support. So people with prostate cancer need to know other people with prostate cancer and talk to people, and I think that's why you're here. And organizations like this, it's really, really important. In the kidney cancer world, we have Kidney Cancer Canada, and they get together like that. Here in prostate cancer is even bigger. And so it's nice to be able to share stories and share advice and just get comradeship from each other. There are great organizations just like this one. This is their website. You've probably seen this website before. That may be how you got here to this lecture. But PCCN is definitely something that we support. There's more support available too at the Tom Baker. So there's a whole huge department called psychosocial oncology. And so psychosocial oncology is available to anyone with cancer. It's no fee, no referral needed. You just call that number and then you get access to our psychologists, psychiatrists, counselors, social workers if you need help with income and stuff like that. And so it's actually really, really helpful. Sometimes people need to really talk about their feelings, what they're going through, and they might not be recognized. You might not recognize them yourself that you have these feelings, but then you go and then suddenly you know why you're feeling this way. And I think it's really, really helpful. They're great for stress management. They're great for individual and couple counseling. So they're actually really, really helpful. And they're a very powerful group in our organization, and we're so lucky to have them. Their phone number is right there, 403-355-3207. You don't need a referral. You just call and they're free. Intimacy is important. So sex is important. I just said that out loud on video camera. Couples intimacy can be affected with a diagnosis of prostate cancer and treatments for prostate cancer. So if you're interested, there are afternoon workshops regularly offered throughout the year. They're presented by one of our world-class clinical psychologists, Dr. John Robinson, and he actually has a special competency in sexual medicine related to urologic malignancies. There's even a urologist sexual medicine expert here in Calgary, Jay Lee, for issues related to erectile dysfunction or AIDS and prosthesis and stuff like that. And so there are all sorts of different things out there to help with couples intimacy. And again, it's something that's free, available, and the phone number is right there, 403-943-8958. Exercise. So exercise is actually also really important, not just for prostate cancer, but for many cancers, breast cancer, all sorts of cancers, and even caregivers. Exercise might help caregivers as well. So at the University of Calgary, there's actually this study, the RECHARGE study, looking at exercise in caregivers. So we're not talking about the prostate cancer patient, but we're talking about the caregivers, and trying to see whether or not exercise can actually improve mental health. health, improve well-being, improve the well-being of of the patient, and so I think it's really helpful. There is a program called Thrive here in Calgary, so if you just Google Thrive, University of Calgary, it's actually an exercise program for all cancer patients, and so if you're interested, you can sign up, you could Google them. They're actually a very one of the most world-renowned groups, actually, for exercise in cancer therapy. Dr. Nicole Koulos-Reed is, she's published a lot on that, and so we're quite proud to have her here in Calgary. And finally, here's a list of more resources. So, Alberta Health Services is where the Tom Baker Cancer Center is. And we have a GU program nurse coordinator, Shay, and she helps with all the referrals from your urologists. If you're not hearing from us for some reason, or if you're missing an appointment from us for some reason, you can always call Shay. Or even if you need help navigating the system, you can call Shay to see what's needed. Similarly, at the Prostate Cancer Center, our friends at the Rocky View, Dave Bateman is the clinical director there, and that's his phone number as well. The last part I want to focus on is clinical research trials. So clinical research, clinical trials is super important. This is how we advance prostate cancer treatment. And the Tom Baker Cancer Center hosts a lot of clinical trials. The Prostate Cancer Center also hosts clinical trials. Those are for localized disease patients. And we usually host clinical trials for the castrate-resistant prostate cancer population. And so if you're interested in participating in clinical trials, please ask your oncologist. What are some examples of clinical trials? So examples right now of clinical trials that we have right now are, people with castrate-resistant prostate cancer. Should we use cabazitaxel chemotherapy, or should we use those oral pills? That's a randomized controlled trial to find out in the future. Just exactly your questions, sir, about which therapy should we use first. That's going to help us answer that, because we don't have the answer to that. The second thing is the Radium 223 clinical trial. So I said Radium 223 will be available soon, but in the meantime, there's a clinical trial for Radium 223 where patients with bone metastases, so you can't have liver metastases, you can't have lung metastases, patients with bone metastases get Radium 223 with Abiraterone to see if it works better than just Abiraterone on its own. There's also another trial of OGX427. It's a mRNA nucleotide, and what it does is it might prevent your body from producing protector proteins to make prostate cancer grow faster. And so we combine that with Abiraterone. So that's a clinical trial too. Of course, you can always bank your samples, so prostate cancer samples or urine samples or blood samples. That's very helpful for future research, and I'm sure the people in the room with prostate cancer have already been approached. And finally, there are lots of radiation clinical trials too. Now, the radiation clinical trials at the Tom Baker are all for localized disease, so not metastatic disease, but disease that's right here in the prostate. And so they have it for high-risk patients, low-risk patients, intermediate-risk patients. There's lots of clinical trials available there. So this is the future of prostate cancer treatment. And why do I say that? I say that because many of the clinical trials that we've done at the Tom Baker have actually led to these brand new drugs being developed and actually approved. So for example, at the Tom Baker, we had clinical trials for Abiraterone, enzalutamide, docetaxel. So we've been using these drugs for way before they were even approved. And so that's what's cool about clinical trials. You get exposed to the cutting edge, the newest, the hottest, the sexiest drugs for your prostate cancer in an effort to try to extend overall survival and make prostate cancer better. So please sign up, ask about clinical trials. Treatments will change. They will get better, and the treatments will allow us to do better for your prostate cancer. So that's all I have to say. I really appreciate all of the questions that I got in the room. It made it really interactive, and I'm glad to have done that. And you know what? We're here to help. And so we're at the Tom Baker Cancer Center. You have our phone number now. You know where we are. And so if you have any questions, let me know. Thank you very much.
Can we still ask a question?
Yes, go ahead.
We heard in the Warriors meeting this morning there's papers going around very recently between intermittent and total hormone treatment. What's your talk on that. Most of us are on intermittent,
Yeah.
but there seems to be some research, or the person who introduced intermittent is now saying that he's re-looked at his papers and the research and the results, and perhaps he was wrong, that people should be actually on total hormone treatment.
So that's a really good question. And it's important to divide that question into two, because there are two answers to that question. The first part is for people without metastases, with the PSAs going up. What do we do with that? For those people, intermittent hormone suppression is perfectly fine, because there's a clinical trial, a large clinical trial that looked at people with intermittent versus continuous. I think you meant continuous hormonal suppression. And those people did absolutely the same. There was no difference. So if you don't have metastases, just a rising PSA, intermittent hormonal therapy is fine. The second part of the answer, though, is for people with metastatic disease. People with metastatic disease, also a rising PSA, but more importantly, metastatic disease. Those people, there's more evidence to suggest that continuous hormonal suppression is better. All right? And so those people, there is also a clinical trial comparing continuous hormone suppression versus intermittent hormone suppression. The statistics of it are debatable in terms of how you interpret it, but basically, if you can be on continuous hormonal suppression, that's actually what we favor for patients with metastatic disease. There are some exceptions. So an exception is someone who hates hormonal therapy, that would rather not be on hormonal therapy, they'd rather go somewhere else. Those people, you can talk and make an educated discussion, have an educated, informed decision about intermittent hormonal therapy. There are other exceptions as well, but for the most part, for metastatic prostate cancer patients, we favor continuous hormonal therapy.
Is that something fairly new? Because I've been on intermittent and it's never been discussed in my situation.
No, that's
and it's like I'm 4 months, then off for a 8-month period, and then you go back for 4 months, and then you come off. So is this something new at the Tom Baker Center?
I wouldn't say it's something new, but it's something that's always evolving. And so whenever new things come up, we always have to wonder, does that new thing apply to the patient sitting in front of me? And who knows, maybe your oncologist said no, I don't know the particularities of everyone's case, but that's something to discuss with your oncologist, because we do prefer continuous therapy, but if you've been on intermittent so long and everything seems to be fine, why change something that's broken? And so, so I don't know if that's the case in your situation, but whenever something new happens, we always have to interpret it in your context. What's already happened to you? A good example is, remember I was talking about using docetaxel chemotherapy for hormone-sensitive patients? We didn't used to do that until about a year ago. So we actually don't do that for everyone. For people who have been on hormone therapy for 3 years and they're still doing very, very well and have castrate-sensitive disease, we don't go and give them chemotherapy because we don't change what's broken. So that might be another example of that. But it's something to ask your oncologist and discuss. We always encourage open dialogue with your oncologist because we want to make sure you're as educated as possible and you're involved in the decision-making process.
It sounds as though this is continual new thinking that you're going through at the moment.
There's always new thinking happening. Yeah.
A question?
Yeah.
And maybe a question that would result in a longer answer than you want to provide.
That's fine.
What is oligometastatic disease, and how does that differ to the states that you described here?
Mm-hmm. Thank you for that question. The question was oligometastatic disease. What is that? Oligo, in one of the old languages, just means few, all right? So few metastases. And so, arbitrary number, 3 metastases or 2 metastases, as opposed to someone who has 50 metastases, or their bone scan has tons of things in their bones. So what's the difference? They're both metastatic disease. They're both in the same disease category. We actually treat them fairly the same. For patients that had castrate-sensitive disease, we used to think that the oligometastatic patients we didn't give chemotherapy to, so that's sort of a nuance, but now we don't follow that anymore. So Stuart, that may be a nuance that was there, but isn't there as much now. So basically, there's this trial that was presented in June, the STAMPEDE clinical trial. Basically, for castrate-resistant disease, it doesn't matter if you have oligometastatic disease or many metastatic disease, we still would be able to offer chemotherapy. Did that answer your question? Yeah.
You can come back and give a whole lecture on that sometime.
I'd be happy to. Do you have a question?
Do you have any solutions in terms of drugs for the fatigue that Xtandi produces?
That's a great question. That's a hard question to answer. So fatigue can be managed by a few ways. So sometimes we reduce the number of pills of Xtandi you're on. So sometimes, instead of taking 4 pills, we take 3 pills, see if that improves things or not. Does it affect the efficacy? It's hard to know. It's hard to have a crystal ball, but it might not if you're getting that fatigued. It might be worth it to feel not that fatigued. Believe it or not, exercise works for fatigue. So a lot of people think, how can that be? If you're fatigued, why would you go exercise? But it's actually paradoxical. If you go start exercising, you actually build up the endorphins, maybe pain doesn't matter as much to you anymore, or maybe you're tolerating things better and you actually build up more energy. We have to do a mood check to make sure you're not depressed, because that can cause fatigue as well. We should also check your thyroid gland, because a low thyroid can also cause low energy. So there are lots of little things that we can check. But you're right, for the most part, it's because of the enzalutamide. Sometimes we have to reduce the dose and it makes it better and tolerable. Anyone else? Great job. Well, that was fantastic.
Danny, thank you. I've heard that. I've heard a number of presentations here at with different cancer therapies, and to have one as well presented as we had tonight, I think we're very fortunate, and in particular, I'm always impressed every time a person like Danny comes out to speak to us as to the advances that are going on right here in Calgary and Alberta and Canada at large, shall we say, that are really very present a very hopeful future for those of us dealing with prostate cancer, cancer generally. And I think we're really fortunate that we've got a person like Danny at the doing this kind of research. Anyway, thank you very much.